position at the peristernal long axis view, then you tilt your probe upwards, and you can see your structures. You can have the superior vena cava, the right atrium, the inferior vena cava, and I mean, this is the superior, going down to the right atrium. Inferior vena cava, I can hear the eustachian valve and the coronary sinus, tricuspid valve, and the right ventricle. This is my system that I do, so I don't miss any structures. And as you can see, there is some tricuspid regurg there. And my question to you is it severe? Is it mild? Is it moderate? Okay? Keep it, remember this picture, okay? Because sometimes the next message advice I would say, you will need more than one image plane. Doing echo for only a single window or a single plane is not enough, okay? Remember, you might need to look in more windows. So this is another picture. This mass here, it's a benign mass, okay? It's hypermobile. It's not mobile, it's hypermobile. It's attached to the eustachian valve, okay? And this was a 15-year-old boy who had this mass there. I don't want to like go into details, but the TE was normal for him. This, however, is a more malignant, let's say, is a thrombus. You can see it attached to the roof of the right atrium, okay? And it's not attached to the eustachian valve. So, and its mobility is different from the previous one. Then the peristernal short axis is a very important structure because you start looking for the left ventricle ejection fraction and abnormalities. So the probe is back on your, well, it's going to be on my, yeah, it's on your left. So the probe is in the same position at the peristernal long axis. Then I just rotate to 90 degrees, okay? And that is my structure over here. Too many to know, but again, I start in the middle with the aortic valve, then I go to the pulmonary valve, pulmonary trunk and branches, the left atrium, interatrial septum, RV, tricuspid valve, and the RVOT. This is my system, then the surrounding structures. Then you can see very easily when you zoom, and you can look at the aortic regurg. This is a very big aortic regurg. Then when you slide the probe down towards the fifth intercostal space, just below the nipple, just you slide the probe down there, you can see the first structure of the mitral valve, and this is where you see your regional wall motion abnormalities. And as I said, this is a good site for looking for mitral stenosis. You can see thickened valves, leaflets, and commissures. And then if you look here, very nicely, this is a patient who had ischemic insult. He had a scarred LAD area. But my point for you, just not only the scar, look at the inferior wall here. It is contracting very nicely. If you look at the next image, okay, remember that the basal inferior wall is common misinterpretation for hypokinesis of the inferior wall. For example, so if you have a patient with the echo, you cannot see the inferior wall because of the diaphragm, and most of your patients will be intubated. So the inferior wall will be like tricking you that it is akinetic, however, it is normal. So how do you know that? I will show you next. This is, unfortunately, the video is not that well, but the posterior wall over here is not contracting very well. Okay, I'm not seeing it very well, it's difficult. So what do? I go to the next view. This is the mid-level, okay, peristernal short axis at the mid-level. And basically, I'm seeing here that the wall here is nicely contracting. Okay, so if the basal level is ischemic, this level should be ischemic. Okay, you cannot have an ischemic level above there affecting the basal wall and not affecting the mid wall, because your blood supply starts at the base, then at the mid, then at the apex distally. So that's a good point to remember. This is another view. You can see there is global hypokinesis, and the ejection fraction here is very poor. I'll say the estimation around less than 35%. Okay. Okay, this is the apical view, and you can see that this is a very good view to assess for the left LV thrombus. Then at the apical four-chamber view, I'll just go very quickly. You can see this is your normal LV. This is a sick patient with actually lymphoma infiltrating the heart, sick patient. This is a sudden onset of dyspnea with RV dilation. And there is a McConnell sign. Maybe I don't have time to go through it. But remember that echo cannot diagnose PE. It can help you if you find a thrombus or a mass in the pulmonary trunk, okay? This I can be very assured about it. But if I have only a McConnell sign, remember McConnell sign is present in 30% of your patient, not that much. You still need a CT and you still need a clinical correlation. So don't wait for your patient. This is the patient I told you about the tricuspid valve regurg. He has a very severe TR. So you need more than one image plane. Then at the apical 2 chamber, I'll just skip through it. This is a normal chamber. Then you have this globally hypokinetic, that the heart is only contracting in the base. This, the next patient, there is a surprise here hidden. Okay, as you can see, it's some contraction there, but the mitral valve is calcified. And there is a left atrial thrombus hidden in that echo. But remember that transthoracic echo cannot exclude left atrial thrombus. Okay, it's a very important message. I'll just go skip very quickly. The subcostal view. The subcostal view here is very important because these are the normal structures you will see. You can detect simply an ASD, but however, you just rotate the probe to 90 degrees. Okay, you can see there is, you can detect the IVC. And this is a true case scenario for a patient, a 60-year-old with ST elevation MI, that was lysed, suddenly collapsed in the CCU. So the parasternal and the long axis, short axis, and the apical views were very poor. So what did we do is, I did for him a subcostal, and you can see, I cannot see the RV, okay? So I can here see the LV is here, but the RV is completely collapsed, and you can see some masses here. There could be a clots over there. So the IVC was very dilated, okay? So I called the cath lab quickly to bring the instruments for drainage of tamponade. I did for him a quick TEE, and you can see this is the right ventricle is collapsed here. Then I checked the cardiac output for this patient, and you can find there is a respiratory variation, and the patient has tamponade. So very quickly, we injected the patient with some saline, and you look at the RV, it was dilated, and it was much better now. The effusion is less, and the cardiac output was restored, and the patient was off inotrope within 10 minutes. I mean, maybe less than that. Quickly, the suprasternal, you can see a flap presenting here, especially in the emergency, and the dissection flap was present at this stage, and the patient was sent to OR very quickly and diagnosed with the dissection of the aorta. Before I conclude my presentation, remember that LV ejection fraction is only a single component of LV function. You have systolic, you have diastolic. This is the LVOT, i.e. the stroke volume for a patient, okay? Believe it or not, the ejection fraction for this patient was less than 35%. It is normal, okay? And this explains why some people, they do well with low ejection fraction. So my message to you, LV ejection fraction is not everything. So remember, just to conclude, ask yourself, why do I need the echocardiography? I'm not using it to look for fancy stuff or to diagnose fabulous stuff, okay? Sometimes it can help you with simple management of cardiac output. Then you have to know you have to know your views, planes, and maneuvers. Please cover all your structures. Use all of your tools available. Take your time and think, and call us for help. We are not your enemy, okay? We are your colleagues, okay, in the other departments. So it will be very helpful. Thank you very much for your attention.
Good morning again. This is it. You'll get rid of me after this lecture. For those of you who have just joined, my name is Mike Allison. I'm from Baltimore, Maryland. I've trained in emergency, internal medicine, and critical care. And I have a particular interest in the use of ultrasound in cardiac arrest. So imagine you're going into the ICU, your next shift. You're walking in, you're turning the corner. First thing you see on the monitor is a rhythm. You hear a bustle of activity, and then you hear that noise. It's not playing, but you know that noise of asystole. The first thing you're going to do is get your team mobilized and put things onto the patient's chest, rhythm analysis, start compressions. But when we're monitoring our patients in cardiac arrest, our standard has been to take our fingers, put them on a peripheral part of the patient, maybe central, and try and see if we can tactilely feel a pulse. What if there was a maneuver we can do, easily accessible at the bedside, to see inside the heart, inside the chest, and see what is actually going on? If only such a technology existed, maybe that could help us during our cardiac arrests. So you had a nice introduction to echocardiography, and here are some emergency images that you're seeing of patients in cardiac arrest. You're noticing that some of them, you're just noticing a little bit of swirling of blood in the ventricle. Others are having a little bit of contraction of that left ventricle. Maybe bradycardic, but they're contracting. Others you're seeing very little at all. And one you're seeing some flickering of a valve. So these are all patients with no pulse, but the images are very different. And maybe you're seeing some dilatation of the right ventricle in one of them as well. So how can we use echocardiography and ultrasound to inform our decisions in cardiac arrest? I think this is going to be a revolution, and I think this is going to change practice potentially. And I think this is a very important topic to talk about. By way of a roadmap, we'll talk a little bit about an overview. And in 20 minutes, I don't think I can get through everything involving ultrasound and cardiac arrest, but I want to provide a basic overview that allows you the information you desire to go and read more on the topic. But I want to talk about two parts of cardiac ultrasound in arrest that have new data, and both are not yet published, to inform our decisions about whether we can stop CPR based upon what we see on ultrasound, or any adverse effects of using, an in particular adverse effect of using ultrasound in cardiac arrest. So here we are in our resuscitation room. By overview, we had come in, we see that shockable rhythm, put that probe away, right? Because we know that what's going to best benefit this patient is great compressions, early cardioversion, cooling, and potentially catheterization, the 4 C's. We don't need ultrasound in this algorithm, at least not right away. This is time sensitive. You want electricity, not sonography. But the patient with PEA arrests that we're seeing often, especially our in-hospital arrests, are complicated. And I think ultrasound may help. Our traditional teaching has been to go through a litany of H's and T's that some may even exist and cause cardiac arrest, and some may not even often cause our cardiac arrest. But we go through this mental exercise nearly every time we're seeing our patients with PEA arrest. And can echo help inform our decisions in patients with hypovolemia or hemorrhage, pericardial tamponade, tension pneumothorax, myocardial or pulmonary arterial thrombosis? I think so. So here we see another example, you've seen a couple already today, of pericardial tamponade, right ventricular dysfunction. And if you saw this in cardiac arrest, if you saw some fluid around the heart in cardiac arrest, you change your decisions instantly. Possibly somewhat more complicated is if you get this apical view of the heart and you see that RV dilatation, that RV that's supposed to be 60% of the LV, that RV looks way bigger than the LV in this picture, greater than 1. In the patient presenting in cardiac arrest, are we thinking pulmonary embolism, systemic thrombolysis, maybe ECMO? And then taking ultrasound in our patients in arrest and looking at the chest, looking between the ribs, we're seeing that bright white pleural line. On the left-hand side, you're seeing some shimmering. You see that white line, it's the pleural line, it's shimmering. You see some movement. And by performing a contralateral exam on the right side, you notice that there's some difference. There's no movement there. There's some artifacts. And as you advance in your ultrasound use, you can know that this, in a cardiac arrest patient, makes me way more comfortable putting in a right-sided chest tube to decompress the chest. But it's not perfect. It's not perfect because I showed you some perfect images, and that's not when cardiac compressions are taking place. You have to pause compressions in order to get a view of the heart. So you still have to do pauses and compressions unless we're moving on to TEE, which would be another topic in and of itself. So can you make assessments of the heart while those compressions are there? I think it's pretty limited. Algorithms have been developed. There's a variety of them that have been put forth in the literature to try and help us use ultrasound in an algorithmic fashion to determine what's going on with these patients. Knowing exactly the steps is not important, but knowing that you're using focused ultrasound of the heart and focused ultrasound of the lungs, and then not in this view, focused ultrasound of the veins, can potentially inform our decisions. Another complicated algorithm, slightly different. Just know that these protocols exist, but none have yet been validated. So I think we're in the early phase. I think we're in the phase where we're starting to adopt this technology and trying to understand where it's going to take us. But there are things that we do know. I think there are things that we do know, and I want to talk about stopping the resuscitation. If you look at ultrasound and cardiac arrest literature for the past 10 to 15 years, this is the topic that has been most published. And it started out in 2001 with this article in Academic Emergency Medicine that was pretty telling. When 169 patients had point-of-care ultrasound and cardiac arrest, 136 had cardiac standstill, and of those 136, none survived. That's an amazing difference in the utilization of resources if this could be replicated, right? If we can just look and know that this person is not going to have ROSC, we're done. We can see our next patient. We're not going to waste our resources. In the same journal, that same exact journal that year, some investigators looked at the combination of ultrasound plus capnography. And just speaking of the ultrasound portion, 102 patients, 61 without activity, 3% survived. Not zero, but low. Take us to the year 2010. So there's a couple studies in between, but take us to 2010. 100 cardiac arrest patients, 34 had no visible cardiac activity, 11% survived. So you see we've gone from 0 to 3 to 11. And of course, when you have studies like that with a variety of different patients, the logical next step to get your next publication is to do a meta-analysis and systematic review of the literature. So they pooled all of these studies together and found that there were about 568 patients that were included in studies with higher quality of evidence, and they performed a meta-analysis. 2.4% of these patients with no discernible ultrasound activity had return to spontaneous circulation. But before it being included in that study, published in the same year, so not included in that meta-analysis, is this assessment of ultrasonography and predicting outcome that showed a 45% chance of getting ROSC, even with no discernible cardiac activity. And I put in parentheses, I think the crucial piece of information that we want to know is what is survival, what is ROSC? This was 20 minutes. Does that inform decisions? Is it survival to ICU admission, to hospital discharge? What about neurological and functional outcomes? We don't have that data. But a group came together, the Reason Group, Real-Time Emergency Assessment with Sonography Outcome Research Network, and they decided their first study was going to be on the standstill cardiac imaging in cardiac arrest. Multi-center trial in North America. This is not yet published, but if you go onto Twitter and the blogs, the investigators are talking about the results because they're interesting. So this will be coming out soon. They looked at survival to hospital discharge. So that's a unifying survival to hospital discharge. And they were able to include a large number, a total of 800 patients that got ultrasound during their cardiac arrest. If you had cardiac activity, 2.7% survived to hospital discharge. If you had no cardiac activity, still 1%.
5 minutes.
Thank you. So I'm not sure we're ready to stop that resuscitation just yet. People are still surviving to hospital discharge. The absolute difference is only 1.7. Are we going to stop our resuscitation in all patients and miss out on that 1%? I'm not sure if we have the answer just from ultrasound. I think we have to keep other aspects of our resuscitation in mind, patient characteristics, the same selection that was talked about with eCPR. The 89-year-old woman coming in who has a history of coronary disease and has cardiac standstill, you're going to make one decision if you see standstill. The 45-year-old marathoner who collapses 1 kilometer prior to the finish line, you're probably going to make a different decision with that patient in standstill. My last topic is I want to talk about the pitfalls of use of ultrasound in cardiac arrest. We know it's important. We know compressions are important, and we've known that since the early 2000s, that compressions and chest compression fraction determine survival in these patients. So it seems like a day where we like to put on videos from The Office. But this is the Stayin' Alive tune, and you see Michael Scott was doing some good compressions, but I think he got distracted. So they don't know what's important. They weren't focusing on the compressions, but we know what's important, and we want to focus on compressions. So when we get cardiac arrests into the emergency department, our residents are running over with the ultrasound now, and they're using it as a pulse check nearly. They're using it every single time we're taking hands off. And I noticed that these checks were longer and longer and longer. Because you're not seeing anything, again, during compressions. You'll only potentially see something and be able to interpret the image once you stop that cardiac compression. And how long does it take you to interpret that image, make a decision, decide what you're going to do? How long does it take you to acquire that image? So I got our medical director of the emergency department to install some cameras. We did some videotape. We videotaped all of the resuscitations that we were doing. And we looked at the pause in chest compressions. We looked at, yes, was ultrasound used? If you used ultrasound during the chest compression, during the pause in chest compressions, what was the time of the pulse check? 21.6 seconds. What if you didn't use ultrasound? 13.1 seconds. So again, not adhered to the guidelines, but you see that difference. So I want to tell you that this is limited. This is a pilot study because we wanted to first establish whether it was worth looking at in only 14 patients. We've now increased the number to 25 patients. We did have some significant difference statistically, and we'll continue to analyze this data, and hopefully this will be something that will make it into the literature to inform our practice. Because getting a view of the heart before you stop the compressions, maybe that can decrease time. So maybe we shouldn't just stop ultrasonography and cardiac arrest altogether, but if we can see the heart moving, we can shorten the time that we have hands off by getting that image earlier and quicker, making quick interpretations. And if we're cognizant of the fact that we're making longer decisions and we're taking a longer amount of time when we use ultrasound, we can potentially improve that behavior, having somebody check that behavior for us. So I only have 2 take-home points for you. I don't think echo results are the sole reason to stop CPR. You still need to use your brain, not just the ultrasound machine. That's good for us, good for the brains. An echo during CPR may adversely lengthen the pulse check duration. And I think we're getting some preliminary data on this. And I think it's worth looking into more because we know that the chest compression fraction is really important. We know we need to do good quality CPR. And if ultrasound is going to interrupt that, for the few patients it benefits with the pericardial effusion, the PE, for those few patients that it's potentially benefit, it may be hurting the vast majority of patients that we're trying to do good CPR on. So thanks for your attention. I'll take some questions at the break.
Thank you very much, Dr. Allison. Now, for our third speaker, Dr. Giovanni Volpicelli. He's an emergency physician from San Luigi Gonzaga University in Italy. He's a fellow of the American College of Chest Physicians and a member of the American College of Emergency Physicians. He has a great interest in ultrasonography and critical care, and he was the chair of the scientific committee of the first International Consensus Conference on Lung Ultrasound. He's also a member of the scientific committee of the second International Consensus Conference on Ultrasound and Trauma. He's a member of the board of directors of the World Interactive Network focused on critical ultrasound, and also the director of the Lung Ultrasound Group, and actively coordinating the international program of education on ultrasounds. He's editor-in-chief of the Critical Ultrasound Journal and member of the editorial board or reviewer of many international journals, including the New England Journal for Medicine, American Journal of Respiratory and Critical Care Medicine, and American Journal of Emergency Medicine. I would like to welcome him and ask him to present his lecture, which is Clarity in Darkness, Use of Ultrasound in Perioperative and Critical Care Medicine. Thank you.
Thank you. Thank you for the presentation, and of course, thank you for this very kind invitation to Kuwait. This is my first time in Kuwait. The topic, the board assigned to me is quite wide because use of ultrasound means use of multi-organ ultrasound. So, but because I have only 20 minutes to speak, and because my main interest in research is lung ultrasound, I will only speak about lung ultrasound, and also because other presenter before me spoke already about cardiac ultrasound. What is lung ultrasound? It is possible to define lung ultrasound in a very few words. And these new words describing lung ultrasound came in the last, I would say, 15 years, no more. Because before these 15 years, the last 15 years, ultrasound was considered not useful to study the chest diseases because, you know, air is inside the lung, and air is the enemy of ultrasound for physics reasons. But now we know that we can use ultrasound to make a differentiation between these three main patterns that are showed in this slide. First, it is not true that it is not possible to see the lung. As you can see in this pattern here, we can see a perfect image of the lung. And this is because in this lung there is no more air inside. Whereas when we have a normal balance between air and fluid inside the lung, then of course we only see artifacts. And there is a pattern that is in the middle where you have less air than normal, but not totally lost from the lung. That is the interstitial syndrome that is in the middle. So the modern era of lung ultrasound is the interpretation and the application at bedside of these three basic, very basic patterns that any one of you can see just by putting the probe on the chest wall of your patients. Lung ultrasound, in a very simple words, is just a densitometer of the lung. So we can use ultrasound to measure the density of the organ. And ultrasound is sensitive to variation in the balance between air and fluid in the lung when air is lost from the lung. That is perfect because most of our patients have this problem in the ICU and especially in emergency situations. And this is just very well, in my opinion, displayed in this screen. So we have a wonderful tool to measure the density of the lung. This is wonderful, but of course, this is also a rough methodology. No one can say what is the disease of the patient by only using ultrasound. We can only say, okay, the lung is more dense than normal. The lung is losing air. But we cannot say if this is due to cardiogenic edema, for example, or ARDS, pneumonia, telectasis, and so on. So we have a wonderful method to measure the density, but not enough specific. So it is a very rough methodology. In this slide, we have a situation of pneumonia where we have, in the same area, in the same lung, two different parts of the lung with different density. So this is the demonstration that we can use ultrasound to measure a different density in the lung tissue. A consolidation on this side and the interstitial syndrome on the other side. So this means that here there is more air than in the consolidated lung. Simple. And we can even use this power monitoring patients. Because, for example, this patient had an atelectasis due to obstruction because of a thrombus in the airways after a trauma. And just removing the thrombus by bronchoscopy, what we observe in a few seconds is the change in aeration of the lung, going from the atelectasis to the interstitial pattern. Perfect. It is really very powerful. But still, don't forget that it is a very rough methodology. Indeed, I will show you, and you know, we have two different mechanisms of increasing density. Lose lung deflation and increasing fluids. But it doesn't matter for lung ultrasound. We can observe increasing density. Any mechanism is the cause of this increase in density. And this is the sentence coming from the statement coming from the consensus conference in lung ultrasound saying that we can use this tool to follow the change in aeration, in lung aeration, following these four main patterns. You must consider that these two in the middle are a variation of the same interstitial pattern, more or less deaerated. So, in our patients, we can follow a situation of loss of air, or we can follow also the increase in aeration, so recruitment. So we have a rough methodology, but I will just focus on some new application of lung ultrasound that will show you that this rough methodology can allow us to make very advanced application in critically ill patients, very complicated patients who are the patients we care about in our daily work. So we can assess pulmonary aeration, and we can use a score, a simple score, studying 12 areas, 6 areas per side, 2 anterior, 2 lateral, and 2 dorsal. And then we combine all these areas, giving to each area a score based on the patterns I showed you, from 0 to 3. And then we combine all the areas, and we have a full score of the patient, giving to us an indication of the kind of the degree of aeration of the lung of the patient. And then we can use this information, putting into our software, following up the patient during days and during hours, during the hospital stay, of course, like this group did in this slide. We can monitor alveolar recruitment, and this was shown in this wonderful study published in the Blue Journal by the French group. And we can give to each improvement of each area a score following this reaeration lung ultrasound score that I show you here. And we can compare, of course, this change after a treatment, or even we can compare reaeration score in each area of the lung, because you know we have the problem to assess regional change in our lung, in the lung of the patient. And this was in agreement with the pressure volume curve methodology that was used as a standard reference. We can monitor pulmonary congestion in the cardiology setting, for example. And this is the first paper showing this power of lung ultrasound in acute decompensated heart failure patients admitted to the hospital, just observing the change in each area of the B-line score. B-lines are the sign of interstitial syndrome. We can follow up the change and the improvement of our patient when we give the treatment of these patients, on these kind of patients we have. Another very advanced application is the hemodynamic assessment that we can use lung ultrasound to improve the assessment, the hemodynamic assessment in our patients. There was this paper that was first published in 2009 by the group of Daniel Lichtenstein, and what he found in the ICU patients was that with absence of B lines in the lung, the A pattern, this corresponded almost always to low levels of wedge pressure. And this was in a group of patients in only one center. Great. But I think the correlation with the wedge pressure is not so linear with pulmonary congestion. So B-lines means pulmonary congestion. And this was not confirmed in another study that we did, in a multi-center study with many more patients. What we found was that this correlation was not true, because we observed many patients with very high level of wedge pressure, but not pulmonary congestion. Whereas this correlation was much better using the extravascular lung water assessment by the PICO system. What is the meaning of this finding? It is very important, in my opinion. The contribution of lung ultrasound is to provide direct insight into the pulmonary interstitium and detect conditions of fluid accumulation in the pulmonary bed. Whereas the wedge pressure identifies hemodynamic overload that not necessarily is linked to pulmonary congestion. And lung ultrasound is a wonderful methodology to differentiate these two kinds of patients. So we have hemodynamic congestion and pulmonary congestion. They are separated. And why this happens? It is very simple, because pulmonary congestion is a matter of pulmonary pressure, but also permeability in the capillary bed. So you can have situations where you have high pulmonary pressure, hemodynamic congestion, but low permeability.
5 minutes.
Who are these patients? They are the chronic patients, probably, with heart failure, chronic heart failure. Whereas we can have high pressure and normal permeability. In this case, you have pulmonary edema, cardiogenic pulmonary edema. Or you may have normal pressure and high permeability, ARDS, the pulmonary edema in ARDS, for example. So lung ultrasound can differentiate these two situations. Can assess lung tolerance to fluid. No belines, you can give fluid to the patient. And can assess congestion. And then, of course, by monitoring and observing the change during fluid treatment, you